Kia ora tātou. I probably don't need that one. Got this one. Well, it's great to be here on the second day of the Design for Health Symposium and to have the opportunity to say a few words as the Vice-Chancellor of the University. I'd like to begin just by congratulating the people who have put this timely and important conference together, particularly the Good Health Design Group from AUT, but also that's Stephen, of course, and also Nicola from our People-Centred Rehabilitation Centre. According to the New Zealand Heart Foundation's consistent war cry, heart disease is the leading cause of death in New Zealand and possibly in many other countries. But what would you rather die of? Death is inevitable, and we can only prolong life. For how long? Ray Kurzweil, the tech billionaire of Google, and others who are committed to tackling the ultimate problem of death with pills, I think in Ray's case more than 250 pills a day, prosthetics, cryogenics, uploading their minds into computer systems, believe in the real possibility of prolonging life, or at least consciousness, for a very, very long time, hundreds of years or more. Of course, all health issues portend and attend death. We are mortal. We are made of insubstantial stuff and are consistently running down, wearing out, and breaking. Putting to one side Ray Kurzweil and the anti-death movement's optimism and work, which I don't deny may have wonderful spin-offs for enhancing an ordinary terminating life, what seems to matter most for us now is how we can live well and what it means to be healthy for the length of a normal life, whatever that might be. It might be a bit longer than it used to be. And at another level, we could ask, does it matter who has access to that healthy life and its benefits, and who doesn't have access? We know that in New Zealand anyway, health outcomes, and probably worldwide, are demonstrably inequitable. New Zealand essentially has a two-tier health system. If you are rich or sufficiently well off to afford health insurance, you get immediate diagnosis and treatment. If you are poor or one of the average wage earners with no health insurance, you get to go on a waiting list. Often it'll be fine. You'll be seen, you'll get treatment through the public arrangements, particularly for acute conditions. But there's no guarantee of that, and many people fall through the cracks inequitably. The data seems to show that the more that's spent on health, whoever's doing that work doesn't agree with me, and we might need some immediate migraine treatment shortly. The data seems to show that the more that's spent on health in a country, the better the average outcomes in terms of lifespan for its population. Lifespan being one very good indicator of health, of course not by itself sufficient. New Zealand, along with the other OECD countries, has spent more in recent decades. In the 1960s, the average life expectancy in New Zealand was 73 years. In 2014, around the last accurate census, we spent an equivalent of 7 times more per person per year, and average life expectancy was 81.5 years. But New Zealand has as good an average life expectancy as many countries that spend a whole lot more than we do. And we have much better life expectancy than some who spend more than we do, notably the United States, which spends the most with dramatically least effect. If years of life expectancy is the measure of effectiveness, the US spends nearly 3 times as much as New Zealand per person per year on health and has an average life expectancy of 79 years, which is the lowest of all the developed countries. So it's not only how much gets spent, but also how it gets spent that counts, and that is the challenge. A notable feature of New Zealand's life expectancy is that it is markedly bifurcated along ethnic lines. Non-Māori, non-Pacific Island people have a life expectancy 7 years greater than Māori and 6 years greater than Pacific Island New Zealanders. The factors that result in those differences must include socioeconomic effects, geographical access to health services, cultural factors in delivery, amongst many others. The apparently ethnicity-based gaps are slowly shrinking, but they do add to the evidence of an inequitable system. In July this year, the Waitangi Tribunal released a report which found that the Crown in New Zealand has breached the Treaty of Waitangi by failing to design and administer the current primary healthcare system to actively address persistent Māori health problems. New Zealand spends about 22% of all government expenditure on health and related services, and 9% of total GDP goes on health. And that's expected to rise significantly towards the year 2050. On spending per person, New Zealand is currently just below the OECD average, with all the English-speaking countries, most of Western Europe, and Scandinavia all ahead of us. However, no matter how much money is spent, the received wisdom is that health systems are not financially sustainable anywhere in the world. Whatever the model, the current sorts of arrangements for health will not be able to keep up with the future challenges. And those challenges include, according to one statement by the New Zealand Ministry of Health, increasing proportions and numbers of older people who are living longer. The growing burden of long-term conditions such as heart disease, diabetes, depression, dementia, and musculoskeletal conditions. New technologies and drugs, raising general expectations about health services and outcomes. A highly mobile global health workforce that it's increasingly difficult to compete for. New infections and increasing antibiotic resistance, and climate change delivering health and social consequences. Nevertheless, the Ministry of Health has defined the goal for health in New Zealand as all New Zealanders live well, stay well, get well. And for the New Zealand health system, they've envisioned a system that is people-powered, provides services closer to home, is designed for value and high performance, and works as one team in a smart system. If anything like that were to be achieved, it would require changes to how we do things and how we think about health. We need to rethink. This is borne out by a comment by Andrew Wong, the Chief Executive of Mercy Ascot Hospitals here in Auckland, that so much of what we do is determined by what gets funded, and so much of what gets funded is determined by what we did. We need to break that cycle with new thinking and new approaches and new designs. The Ministry of Health again had proposed that success in achieving its vision would be accompanied by new approaches, by shifts, by moving from treatment to prevention, by moving from a focus on the individual to a wider focus on the family and whānau, by moving from service-centred delivery to people-centred services, by moving from competition to trust, cohesion and collaboration, by moving from a fragmented health sector full of silos to taking integrated social responses. But that is all about what Lester Levy, the previous chair of all of the Auckland District Health Boards, has called the sickness system rather than the health system. As much as 85% of health outcomes have nothing to do with the so-called health system. What of these social, cultural, lifestyle, economic effects? How can they be leveraged for better health? And that raises a host of other issues. How and where do we live? future environments, housing, urban design, the natural environment. How do we participate in life? The future of work. How do we function daily? The human body works best when upright, load-bearing and mobile. Where do chairs, screens, seated vehicles, generally sedentary lifestyles fit into this evolutionary schema? What do we enjoy? Food. What kind of food? Where do we get it from? Family. What kind of family? Fellowship. Where and with whom? Loneliness is a major health issue for the old, and perhaps more ages as well in the digital online world that we're in. Adventure. How risky should be allowed in our safety and risk-obsessed world. Play. Do we watch it or participate in it? I'm looking forward to watching the Rugby World Cup starting tonight. I have never touched a rugby ball in my life or run around on a rugby field. Challenges. What do we leave for people to work out for themselves? Purpose is something that makes a life more enjoyable. And what is our purpose? Is it more than shopping? Understanding stuff. What kind of information do people have? Do we generally live in a state of confusion and bewilderment carelessly generated by our current sources of information? And then a life is more enjoyable with a sense of future. And what kind of future? Is there a future? What do we do about the melancholia emanating from the miasma of doom saying that hangs over the world? Imminent extinction, the takeover of the robots, eco-anxiety. In the end, is it enough to deal with what allows us to live, but ignore the answers to why we live? The World Health Organization defines health as a complete state of physical, mental, and social well-being, not merely the absence of disease or infirmity. This is a standard that we might have a way to go if we were going to achieve. But how far should we and could we go? What is a complete state of physical, mental, and social well-being? And who decides? Well-being is the mot du jour, a currently overused word meaning everything and nothing. Perhaps the reason for the present focus that our government has on well-being. Nevertheless, understanding the 85%, the non-health system factors in health, is essential to developing health futures. Coming back to Lester Levy's sickness system, when you're in dire need of the 15% of outcomes that do depend on the health system interventions, at that point, no one is comforted by the fact that 85% of health has nothing to do with the system of health interventions. The crucial questions then are, how do I get the health intervention I need in a timely, congenial, accessible and affordable way? And then system questions, who gets that timely, congenial, accessible and affordable health intervention, and how can we do it better? Whether you choose to live as Māori on your tūranga waiwai in a so-called remote area, or whether you decide to have a baby in Wanaka, a current issue in New Zealand, you should be able to access health. The current health and disability review that has been mounted by the government recently released an interim report. Areas of focus highlighted were integrated care, new ways of funding, technological changes, better management and deployment of facilities and equipment infrastructure, professions and workforce redefined. Are the current professions the ones that will take us into the future? Interprofessional issues, training, employment and well-being of healthcare staff, health information, the problems of parts of the system lacking knowledge of the whole system. When we read these reports from the Ministry of Health or the Disability and Health Review, there seems to be a mood for change. Change that covers the need for an input from a wide range of fields. But is it possible that we will remain trapped in the old structures, with the same solutions being raised as the answer, just with more of them? I'm not a designer or a health professional. I am in charge of a university. So I've been thinking about how do we get the disparate areas of expertise across the university and in the outside world to work together differently to improve outcomes. At AUT, we have the largest health sciences faculty in New Zealand, not only training thousands of clinical professionals, but also conducting leading research in a range of crucial areas. But we also work in a host of other areas that can make a contribution, including engineering, material science, design, IT, AI, digital applications, mathematics and analytics, informatics, economics and public policy, law, exercise science, architecture, spatial and urban design, economics, education and training, management systems, communications and media, demography, Māori and Indigenous advancement, and of course design. We're thinking about how we might bring all that together to strengthen our contribution to health futures. And at the moment we're exploring the possibilities for a pan-university scheme called, prosaically, Health Futures. While university research and current arrangements in New Zealand, such as the CORES, the Health Research Council and the Science Challenges and the medical and health sciences schools do much that is enormously valuable, to some extent we're trapped in the systems of the councils and registration bodies that determine training, the research grant application systems and their panels drawn from the existing prevailing schools of thought. So we're wondering at AUT whether we could commit some of our resource towards some work in the health futures area that takes a different approach, that would both expand our external partnerships and connections and making our lines of inquiry and exploration and creative solution building real and relevant, addressing the most valuable questions, and reduce the internal barriers to collaboration and transdiscipline work within the university by focusing on some defined areas, albeit broadly defined, wicked problems if you like, through intense collaboration, teaching and research with a programmatic approach, still allowing creativity to range widely over known and unknown territory. Now we're still working on how we might do all that. Today's challenge, not just the today of this conference, but today's challenge is to explore the different ways that we can share expertise and insights and approach problems, whether by design or any other current research and development approach, collaborating to improve our collective outcomes. As I said at the beginning, I'd like to congratulate the Good Health Design Group and others at AUT for initiating this conference, bringing together a range of perspectives from New Zealand and around the world in this important emerging field of design for health. It's an initiative from which much good can come. Nō reira, kia kaha, kia maia, kia manawanui, which means be strong, be brave, be wholehearted, and we might say, to add to that, be creative. Tēnā koutou, tēnā koutou, tēnā koutou katoa.